Good afternoon, everyone. Thank you for coming all the way to room 210 BC. Seemed like quite a hike, right? I guess you really wanted to be here. Hopefully I won't disappoint. You're at the Business of Anesthesiology talk. Everything you need to know but didn't know to ask, and I'm Andrew Leibowitz. This is a pretty exhaustive talk, and I'll have a few minutes for questions at the end, and stay for as long as the questions require. I have no pertinent financial disclosures relative to this talk, but as I like to say, I invest very heavily in common sense. The basis of this talk really is it pays to know how your business works, because if you don't know, you will likely not get paid. And also, you need to know a little about any subject in order to use a searchlight effectively, because you need to know what you're looking for, if I may paraphrase that there. I will review the minimum knowledge that I think every anesthesiologist should have. This is not meant to be exhaustive or even authoritative. I'm not going to discuss some subjects that at some points in time are very hot, like MIPS, MACRA, surprise billing, dispute resolution, or CRNA independent practice, but almost everything else I'm going to cover in at least some detail. This talk is really like Anesthesia Business 101. The learning objectives are to have everyone in this audience have insight into these 10 subjects, ranging from macroeconomics, understanding who pays us what, how our work is valued, and specifically what units and RVUs are all about, the current state of compensation, the utility of stipends, which some people like to call subsidies and other people like to say financial support, the genuine costs of running a practice, ND working alone versus in a care team model, directing or supervising CRNAs, common billing jargon, get ready to bundle, and leveraging operating room data. So first off, macroeconomics. I found in the last 6 months, you could learn more about healthcare economics by reading the Wall Street Journal and the New York Times than any other publication, especially the Wall Street Journal, interestingly. The big news here is all in these two graphs. Healthcare is not only a gigantic business, it is the biggest business in the United States. On the left panel, you could follow this purple line. Excuse me, got my other pointer here. You could follow the purple line, and you could see that now about 12.5% of everybody works in healthcare. And on the right, you could see that's 23 million people. And you could also see how those graphs are moving in a pretty straight line right to the upper right-hand corner of the slide. I recommend that everybody spend at least a rainy Saturday afternoon and go to the Congressional Budget Office page and understand what the politicians are talking about and realize they're not being very transparent or honest with us when it comes to money. I know that's kind of shocking, right? On the left, you see where the money is coming from. And you see that mostly it's coming from personal income tax. And on the right, you see where it's going to, mostly to the 4 big mandatory programs and defense. We have a huge deficit, and the costs of Social Security, interest on the debt, I'll get to in a second, healthcare and defense are the main drivers of the expense, while everything else is basically small potatoes. Wall Street Journal today and yesterday had an article how interest on the national debt alone in 2025 exceeded $1 trillion, and being that we're going to add another $2 trillion to the debt, and it takes about 4% to finance that debt. That finance is going to add another $80 billion to the $1 trillion we spent on the interest of the debt just this year. You can see here now in 2025, though, healthcare spending is now 25% of the federal budget and 30% of the budget that's not paying the interest on that debt. Now, for all that money being spent on healthcare, our outcomes are simply not very good. I've circled us on the top here. Life expectancy, simply who lives the longest, we are a whole 2 years behind the next worst and the next most expensive country, Germany, but we spend $5,000 more a year per person than Germany. I happened to have been in Iceland last week. I realized in Iceland, the average male outlives the average male in the United States by something like 5.6 years. It's an incredible gap. And no matter how you slice it or dice it, we're not doing very well in any domain. Or in other words, people talk a lot about value equal quality over cost, but we really have a very low value system when you look at the macroeconomics of things. Okay, who pays us? So they're the government payers. I'm going to spend a lot of time about the government payers in the next couple slides. That's mostly Medicare, that's federally funded. Primarily, that takes care of the elderly and retired set. Medicaid, that's federal and state funded. That's generally going to poor people, disabled people, and children. We have the insurance companies that we have some negotiating power with. The big four, usually sometimes abbreviated Bucker, Blue Cross, United, Cigna, and Aetna. Those companies and others are involved in managed Medicare and Medicaid. They usually simply pay some portion or increase or decrease relative to the usual care and CAID rates. There's very little commercial fee for service in the vast majority of the country anymore, where you simply pay a bill and the insurance company pays a certain percent. And at least where I live, if I look at the front sheet and it says self-pay, if the patient's not from Saudi Arabia, it usually means no pay. Now, here's the big picture on Medicaid that I'm going to highlight, because it now covers 23% of all Americans, more than Medicare. I'll show you that data in a second. And in polling, because so many Americans are covered by Medicaid, very few Americans actually want to hear either party talk about cutting Medicaid, whether you're Democratic, Republican, Independent, because so many people are on this, and you're going to see very often it could be the person next door, or their kids, or their parents. So it's 79 million people on Medicaid, Medicare about 68 million. Medicaid spends about $9,000 per enrollee per year. It covers 33 million children. It covers virtually 1 out of every 2 children in the United States. And in New York City, where I live, 6 out of every 10 deliveries are covered by Medicaid, which is 18% of all healthcare spending. And it also covers 62% of all nursing home resident costs at a grand total of about $60 billion a year. This is an article from the New York Times that got to this point, that so many people on Medicaid that they're kind of like the silent majority to some degree. There are lots of old people that you might think are living a middle-class existence. You look at their face sheet, they have Medicaid. Their grandchildren are on Medicaid. The vast majority of college graduates in 2026 will likely be on Medicaid if they're not covered on their parents' plan. So how is our work valued by Medicare, Medicaid, and these insurers, and on what basis are we paid? Now, there are a lot of words here, but just to start, in the really old days, when I was a kid going to the pediatrician, my parents would go, and the pediatrician would give them a bill, and my parents would write a check, and they'd fill out a form, and they'd mail it to the insurer, and the insurer would mail them the money back. Hard to believe, right? No cell phones, no screens, no Netflix, no nothing, right? That's how it worked until the 1970s. But then the insurance companies got started to only wanting to pay what the usual and customary rates were. Because like every system, it was abused. There would be surgeons, like I'm sure some of you know in the audience today, that charge $100,000 for a microdisc, and others that get a Medicaid reimbursement of $600 for a microdisc. And that was not a very viable situation. So there was a joint meeting, basically, between the Harvard School of Public Health and the Health and Human Services Administration. And in 1989, there was the Omnibus Budget Reconciliation Act that created the Medicare fee schedule, ended that usual, customary, and reasonable approach, and led to the resource-based relative value scale. That's a lot of words. That scale simply means that doctors are going to be paid to some degree on only the basis of their work, their expense, and their malpractice costs. This exists to this day. It's updated every 5 years by CMS with input from an update committee, abbreviated RUC, that advises and reviews the guidance that then Medicare could take or not take. And for everybody's knowledge, there is representation of anesthesiology on these RUC committees. However, anesthesiology has always been treated differently. For the sake of communication, I'm going to go forward. When I go forward, I'm going to talk about an anesthesia unit and everybody else's units as an RVU. But there's a separate fee schedule and methodology for anesthesia services that's simply based on a relative value guide that uses only 2 primary factors. And that's basically the complexity of the surgery and how much time we spend with the patient. So anesthesia units, rest of the world is using RVUs. I'm going to say units for us. In the current state, Medicare, rounding off all the numbers here, reimburses us about $22 for our anesthesia unit. And for everybody else's RVUs, they pay $34 a unit. If anybody's using a camera or anything, if you could find all these documents on these 2 websites. Very good resource to, spend a Saturday afternoon if you want to take a nap. They're very, very long. They're very, very wordy. But just to go back, so anesthesia units, again, these are the base units are determined by the procedural complexity. The time units are usually in 15-minute increments. Depending upon your insurer, these 15-minute increments may be rounded up or down or to the exact minute. We get paid for other things like lines, blocks, echocardiography, maybe point-of-care ultrasound if you do good documentation. And those might be billed using RVUs, especially if you're in a Medicare, Medicaid world. But if you have a commercial insurer, they may be a flat fee for those that are negotiated separately. In my own practice, almost all these things, I've negotiated a flat fee that's not based upon their RVU assignment with most of my commercial insurers. There are modifiers and circumstances that we used to get reimbursed for all the time, like ASA physical status, age less than 1, greater than 70, controlled hypotension, utility of hypothermia, that are now under attack and generally not reimbursed any longer. Now, in the grand scheme of things, most physicians in the regular world, your internist in his office or the very average general surgeon, is aiming to accrue about 7,500 units a year in the RVU scheme. In my institution, that's often the barrier between making your pay versus any extra pay. Anesthesiologists in academic medical centers, and for the most part in most of the country, average about 11,000 units a year. This data is a little hard to parse out because some of us may be working solo in an office, for instance. Maybe you do 2 cosmetic procedures. You don't accrue a lot of units, but you might accrue a lot of money, right, if they pay out of pocket. On the other hand, you might be in an endoscopy center and doing 16 endoscopies a day, or you might be medically supervising or directing a large group of residents and or nurses. So this is a fairly variable number. The average operating room, though, in the United States, according to the MGMA, should generate all alone about 11,750 anesthesia units a year. Now, the reimbursement for an RVU and an anesthesia unit commonly varies 16-fold, right? Imagine you went to Costco and you bought a bag of Thomas's English muffins and you got to the register and it was $4. And the next week you went down the block to Whole Foods and the same bag of English muffins, the same exact bag, not the extra large, not the gluten-free, cost $64. You'd wonder what the hell's going on here, right? But that's exactly how our system works. One of the authors of this paper is sitting over here, so he knows this well. Every year in November, so in about 3 weeks, this article will appear. This is last year's article. It deserves everyone to pay attention. It reveals what the conversion factor is throughout the United States Conversion factor is the key term. That's what it is. An anesthesiology unit is paid by the main commercial insurers. And here's data from 297 practices that represents 12,300 some odd anesthesiologists and about 14 million cases. And you could see that last year, not only was there a decline in the average payment per unit, but the mean was about $80.70. And I'm going to get back to that in just a minute. Just for everyone's edification about the universe that we live in, surgeons' charges and reimbursements are determined by their CPT code that crosswalks to our code that creates our base units. The hospital charge and reimbursement, you should know, is determined by really a Medicare severity diagnostic related group, and that in some way could be increased a bit by minor and major complications and comorbidities. Anesthesia bills require an accurate CPT and an ICD-10 code denoting what the disease was. You can't submit a bill for a colectomy when the patient had a bunionectomy. And you can't submit a bill for a colectomy when the patient had an arthritic toe. Everything's got to line up. So the resources you need are to know the CPT of the procedure, which is now usually booked by the surgeon in Epic so you can see it, but frequently it might change or be incorrect. You need to know the diagnosis of the patient with an ICD-10 guide. You need an ASA crosswalk guide to translate these codes into our codes. And then you need the ASA relative value guide. Dozens, this is commonly misunderstood, dozens of similar surgical CPT codes all translate into the same final anesthesia billing code for our base units. For instance, it doesn't matter whether the patient got a right colectomy, left colectomy, transverse colectomy. For us, they all end up in the same base units. Appendectomy and colectomy, a little different. Appendectomy and esophagogastrectomy, big difference. So let's see how this works here. I'm going to just take an open hysterectomy as an example. The base code for us is 00846. It's worth 8 units. I have a slower surgeon. Maybe it takes 3 hours. That's 12 time units. So I've accrued 20 anesthesia units. Maybe my patient was kind of sick. Maybe I still got an insurer that pays me for taking care of sick patients more than non-sick patients. I might be able to get another unit out of that, but probably not these days. Maybe they're old, same idea. Used to be paid an extra unit. An A-line might be reimbursed on the RVU system, as might use of ultrasound and the tap block. Or I might, if I'm a good negotiator, have negotiated a fee with my commercial insurer just to pay me a certain amount of money for those things. So in total, I got 22 anesthesia units and maybe 3 or 3.05 relative value units for this case. I'm going to come back to A-line in a minute to show you that it's not quite as simple as that. But first, I'm just going to get to the real beef of the story here. We have good payers, we have bad payers, we have terrible payers, right? I'm looking at my New York City 75th% commercial rate, which pays me and my practice a unit of $129. Medicare pays maybe in the best neighborhood, the highest reimbursement rate in my neighborhood, maybe $23. And Medicaid in New York State's been fixed at $10 a unit, maybe since before I was born. But definitely since I've been in practice in the, well, I don't want to say how long. So if I add all those up and I do all the arithmetic, you could see if I have a good insurer, I could walk away with $3,000 reimbursement for that case. That's great. I do 2 or 3 of those a day. I'm ready to buy property, in 3 different continents. If I have Medicare and I do 3 of those, I don't make my expense. And if I have Medicaid, it's really a gigantic loss. It's not quite a 16-fold variation there, but it's way more than a 10-fold variation. So that's the good, the bad, and the ugly, and that's why payer mix becomes so critical when you look at your practices. If you go to the government website and you look up how much I get paid by an A-line for Medicare, you get the graphic on top. There's lots of, I think there are 38 cells that have something in them there. But I kind of simplified it down below so you could see how that RVU system was set up, because there's a work value, a practice expense, a malpractice cost, and a little bit of a geographic variation So if I put an A-line in a Medicare patient in New York City, I'm supposed to be paid $46 from Medicare in theory. Now, the Medicare anesthesia unit conversion factor is not very much money. It's $22, $23, depending upon where you are in the country. It may even be as little as $21. Adjusted for inflation, it's less than half of what it was 20 years ago. And it's been going actually down this year, and it's scheduled to go down next year. Further, because of the big, beautiful bill, it might go down even further. The comments within the bill that I also spent some time reading on a very, very boring Saturday afternoon were summarized in this New York Times article. The government realized that certain procedures, especially the proceduralists, were being paid an amount of money based on the amount of work the procedure required 25 years ago. And the specific comment in the big, beautiful bill was an endoscopist used to take 50 minutes to do a screening colonoscopy or upper endoscopy. And now, routinely, they're doing those in 10 and 15 minutes. So why should Medicare pay them the same old money they were paying them 25 years ago when they could do 3 or 4 times as many in the same amount of time? And we're caught up in that very same vortex. In addition to being caught up in that vortex, there are some tricks that occur in the background. There may be some tricks of the trade if you could manage and make them work in your favor. In our guide, we think that a screening colonoscopy is worth 4 base units. But CMS only allows 3 for a screening colonoscopy, but they do allow 4 if an actual polyp is removed. Now, I know in my hospital practice, it's a very rare screening colonoscopy that doesn't get a biopsy. In the ASC, maybe it's 50-50, but I don't think I've seen anybody not get a biopsy in my own practice. If you don't code that properly, and you're doing 16 screening colonoscopies a day that all also required some little biopsy, you're missing out on 1 unit in every case. And instead of accruing $1,680 at the end of the day, you could have accrued $2,016, right? So it's a nice $300 and change uptick, 5 days a week. That's $15,000. That's $700-something thousand a year. Okay, so what on average does everyone in this room get paid for their anesthesia units? So that's called the blended unit rate that most practices should kind of try to understand. The blended unit rate is essentially all the dollars collected divided by all the units billed. And I estimate that nationally this is somewhere in the area of 48, or just for the sake of conversation, we'll say $50 a unit. Medicaid nationally averages about $12 a unit. In New York State, we definitely bring down the average. We only pay $10 a unit, and we have a huge Medicaid burden. Medicare averages $22 a unit. Commercial, we've seen, averages about $80 a unit. And just rounding up all these numbers, close to a quarter of the country is on Medicaid. A little less than a quarter is on Medicare. Everybody else has got commercial insurance. So it makes sense we're about a $50 a unit on average. Now, I told you that an anesthesiologist accrues 10,000, maybe 11,500 units a year. So maybe the average anesthesiologist is accruing $480,000 to $560,000 in charges. If you look at this in a pie chart, you can see your payer mix has very little relationship to your revenue mix because of that 16 commonly varied amount of money that you get for an RVU from a commercial payer versus the Medicaid payer, right? So on the left, you see the payer mix. Half my patients have commercial insurance, but really more than 3/4 of my collections come from commercial insurance, just about. Again, these used to be paid. You could check your commercial contracts if they're still paid. I know in my contract with United Healthcare, they were supposed to pay me for an ASA 3 or above, and they unilaterally decided not to pay me, and now I have a big dispute with them. I have a very complex population. We do 125,000 anesthetics a year. This difference in policy that reduced my unit value per case by 1 turned out to be more than $500,000 in lost revenue, just like that. So now I have to go and sue them or go into some arbitration or threaten not to renegotiate with them the next time we have a contract renewal. And time may be capped too. I'm sure you've all seen the stories. There's actually a time cap bill that's on the agenda in New York State now. The idea there is if a case is taking way longer than average, you should only be paid the average amount of time, even though you're still taking care of the patient, which is obviously not the way that bill that was created in the 1980s and 90s thought about things. We're supposed to be paid for our time, not the average time it should take. Okay, having said all that, we know where our money comes. I'm just going to address compensation now. How much do anesthesiologists earn? So if you're in an academic medical center, the best source of knowledge is the AAMC survey that I'll show you the direct results of in a minute. There's also an SAAPM survey that's something I just filled out last week. It's a little bit more of a proprietary, and it won't get all of the medical school salaries. There are lots of companies that publish this data. Your institutions, if you have a contract with your institution or an academic medical center, you may use one of these benchmarking companies to decide how much your anesthesiologist should be paid. Or you could just go to Gaswork and see what the local market is. And a practice where I'm telling a small hospital and I'm telling them we have to pay more, there's no way around this, I routinely cut and paste the Gasworks ads from the geographic area around that hospital and say, you could walk from your hospital to this hospital. This is their Gaswork ad. This is my Gaswork ad. We've got to do something here, right? Okay, so the AAMC survey, I like a lot. It goes out to all the schools in the country, and all the schools report all the data. A couple schools sometimes screw up and they don't, so last year I went out to 158 schools, 156 sent the data back. So there's data on 134,000 plus medical school faculty, and it's data from the preceding July 1 through June 30th year. So this comes out in January. I sit at my computer, January 16th or 17th, I download the book, it's $68 or thereabouts, and you can slice it and dice it any way you want. Last year, there were 5,913 anesthesiologists salaries reported, which is about 13% of all the practicing anesthesiologists in the country. And then I slice it and dice it. I go right to Northeast. That's my competitors. There are 28 departments in my region that are used in this survey. And I left out the instructor level, which actually last year was more than the assistant professor, which shows you which way salaries are going. And it reports all this data plain as day. It reports all this data, by the way, for your surgical colleagues, your neurosurgical colleagues, your orthopedic surgeons. So if you want to spend the $70 and get that data, you could understand how your colleagues are being paid also. This is not too different than a lot of other surveys. This is published by the ASA. It's a graphic showing very similar numbers, but not limited only to academic medical centers where the employees are school employees, and relies on AAMC reporting from sources like Doximity, which I don't think is very accurate, ECG Management, Consultants, Merritt Hawkins, Sullivan Cotter. And you can see here, again, back in 2023 at least, the averages hovered in the 500s thereabouts. Well, that gets us to this subject of support. Some of my friends don't like when I say subsidy or stipend, but you could use those words interchangeably depending on who you're speaking to. I like to say support when I speak to hospital administration. I don't like to feel like I need a subsidy. I don't feel like I'm really getting paid a stipend. But now that we know who pays us what, and in general our revenue is less than our compensation, or certainly less than our compensation after expenses, you need some kind of support to make up the delta. So this is what I call like a conundrum between the anesthesiologist's compensation and our unit's accrual mismatch. The fact is that every potentially active room needs anesthesiology coverage all the time. That's just the way our life works. In-house call may be absolutely necessary and totally unproductive. And the need to employ an anesthesiologist at any point in time is not based upon our likely productivity. It's based on the likely possible need for our service. And that's where this discussion really ends up. We may also have revenue that's less than expense due to a poor payer mix, utilization of the sites we're actually working in that are very underutilized or poorly managed. They have late starts, big time gaps, bad turnover. We may cover non-productive sites, like Nora locations traditionally have run very poorly until you really get a nidus of people interested in making those sites work better. And then we have some unreimbursed OR duties. Maybe you have a board runner, you have someone assigned to the PACU, someone on the code team, pre-op clinic, all things that generate virtually $0, but suck up time and effort. Okay, so what's a pro forma is something that we're often asked to give, which simply means look at this practice, tell us what you need, figure out how much money your services may or may not cost. So I'm going to use a very simple example I was involved with very shortly after I became chair. This little hospital downtown, and they had a private corporation that was asking for more and more money, and I was being asked to ferret out whether this was actually a required thing. So this is a basic bread and butter practice. They had 19 rooms. They had a person who worked late who was off the next day. So basically, every day on the schedule, they needed 20 people. If you need 20 people to show up every day, people on vacation and jury duty and get sick, you probably need about 23 anesthesiologists, right? The claim of this group was that their expense was more than their revenue because the practice was inefficient and the payer mix wasn't as good as everyone thought. So my basic arithmetic is there are 253 work days in a year. We all get 30 days off. I figure out this number. I round it up to 23 because hospital administration doesn't understand. You think they're very bright about this. Like, well, there are 10 rooms. Why do you need more than 10 anesthesiologists? I said, well, I need actually maybe 13. They go, well, why can't you do 12? I go, well, half of my anesthesiologists now in this practice are between the ages of 30 and 35. What's the likelihood at any given time one person will be on FMLA? That's about 150% chance. I looked at my OR schedule. I looked at my OR schedule in August. This is no doubt. The 3 hospitals I'm primarily responsible for myself to cover, I have 105 anesthesiologists. 8 were on FMLA for the month of August. So an extra one won't do it, especially if you're in a small group. Unless administration says, well, if Joe gets sick, we'll just close the OR for that period of time. And that's not going to work, right? So you have to build in that buffer. So using the principles I reviewed before, I'll just go through this with a little pointer here, right? I got 23 MDs, some frugal estimates here. They don't do much call. They usually finish early. They only make $500,000 a year maybe. They got malpractice here. They got some benefits. They got also medical insurance and disability insurance and dental and vision. We have to collect the money. We have to pay the agency that does all this billing for us, right? And we have some other miscellaneous fees that I'm just going to say are part of our total budget. On the right, it's everything I told you about. I estimate how many units per room I'm going to get times these 19 rooms, based upon the percentage of Medicare, Medicaid, and commercial, how much each of those insurers are going to pay me. And I come down to here and I go, oh, voila, this practice is not doing so bad. They're going to collect $14.2 million, and they're going to collect $14.4 million, sorry, and their expense is 14.2. They don't need a subsidy. They're just BSing you. They're threatening, but they should be just fine. I was given the wrong data, just like the group. None of this was true. Well, those rooms actually were not so efficient, and the Medicaid rate, the Medicaid percentage in that downtown hospital was not 25%. It was closer to 30. The Medicare was 35. The commercial went from 45 to 35. That's where all the money comes in. And you could see that all these numbers really dropped very dramatically, especially this commercial amount of money. They have the same expenses to just take care of patients that are more poorly insured, but now their revenue will not meet their expense. And if they don't get support, they're just going to fold tomorrow, and then this hospital will have no coverage. So they have to go back to the bargaining table and agree on this. Now, revenue less than expense is the rule. It is not the exception. Here's a snippet of a Form 990. I don't know how many of you are familiar with Form 990s. Anyone? So Form 990s are what every non-tax-paying entity, otherwise known as a nonprofit, company, hospital, school in the country has to submit to the government. It's like their equivalent of our income tax form. Give me one moment, I'll put that up. You could go to this Form 990 that I'm going to get back to in just a second. Sorry about that. And look at this snippet here. This is a standalone corporation that staffs a major group of hospitals in my area that's officially a nonprofit. They do get $424 million in revenue, but they have $449 million in expense. So somewhere, somebody, unless they're working with the mob or something, is giving them $25 million a year to stay solvent. It's the only way the arithmetic works. And if this is a Form 990, you don't need to be an accountant to read. Anybody in this room could figure it out if they stare at it for 3 or 4 minutes. It's very, very easy. Here's an article that appeared in Anesthesiology News in 2024, and you don't need to read the fine print. I'll blow it all up for you, and it's highlighted in yellow. Basically, an estimated 85% of hospitals do pay subsidies. And, of course, the worse the overall payer mix, the bigger the subsidy is going to be that's required. This has even been subject of publication in Anesthesiology. This was published, I think, in 2017 or 18, and it looked at the earlier part of the decade in California about how these non-academic hospitals were requiring subsidies or stipends or support, whichever word you want to use. In brief, the more government payers you have, you're going to see over here, the more money you're going to need because the payments are not going to meet your expenses. And in this particular study, it suggested that your practice, if you had 60% government payers, Medicaid and plus Medicare, you might be subsidized by as much as $1.60 per anesthesia minute. Because your payer mix was so poor, your revenue would never come close to meeting your expense. Now, here's some data I put together from a few sources. And you can see that as a specialty, we depend on a lot of hospital support. And this makes sense. As I showed you before, we're collecting somewhere less than $575 a year, but our average salary before benefits and expenses is approximately that same number. And that's before we also pay the 5% to collect the money that we're collecting. And you could see here, broken down by FTE and department, what the mean, median, 25th, and 75th percentiles are throughout the country. And they're pretty large numbers, and I think somewhat shocking, but they go with that Form 990 I just showed you, if they needed $25 million support themselves. And that's, by the way, I know that set of hospitals is not a particularly heavily Medicaid subscribed set. I've been alluding to practice costs a couple times, so I'm going to get to that now. So there are really 2 slides here. First of all, it costs money to collect your money. It's at least 5%. Even if you had a biller that was only charging you 3%, patients pay with their credit card. The American Express fee is 3.5% right off the bat. So it's a minimum of 5%, probably closer to 6 or 7% when you really add it up. Any practice of any size has needs. I'm in a big academic practice with 400 employees, but even a 20-person employee group may need someone to answer the phone sometimes, design or maintain its website, provide financial oversight, be it a bookkeeper, accountant, a banker, or at least somebody with an MBA perhaps, someone who does critical paperwork, either a member of their practice who does it at bedtime or something, privileging, credentialing, OPPs, FPPs. You need a lawyer to do contracting. All my disciplinary letters, I thankfully don't write that many, but every disciplinary letter sucks up 30 minutes of my time, 30 minutes of my lawyer's time. And then usually some other lawyer from the institution wants to look at it, make a change, and it comes back to us. And response to patients' complaints. I don't know about where you work, but I probably vet a direct written patient complaint that involves anesthesia in some way, for all my cases, at least once a week. And being that I'm in New York, and we have a disease in New York, by the way, called Manhattanitis. It's a very affluent, educated group of people. Everybody thinks they're more important than everybody else and deserve very special treatment that they didn't get. And they're going to write a letter and threaten and send it to the lawyer and put it on X and all these other things. It happens all the time, all the time. We all need malpractice insurance. We all need to realize when we hire a 1.0 person, they're going to be off 5, 6. In our area now, a practice is offering 9 or 10 weeks vacation. They're going to use FMLA time. They're going to occasionally be sick. They're going to come to an ASA meeting. That's going to happen. If you are an employer, you have some payroll taxes. Just like we see taken out of our paychecks as perhaps employees, the employer is also paying its share of Medicare taxes and Social Security taxes. More recently, I'm going to skip to the bottom for 1 minute because this was on my mind. Cyber attack insurance is a big thing now. One of my surgical colleagues who's in a 4-man practice just cut a $30,000 check to pay for his 6 months worth of cyber attack insurance. And he was bemoaning that, but he was also the victim of a cyber attack lawsuit that he's trying to defend with his insurer now that was basically going to cost him millions if he had to settle. So this is like a big business. It's like the next car accident kind of lawyer thing. We all get those letters in the mail, I'm sure, like once a month, your information's been stolen. But if you're in a medical practice and the information's been stolen, now the person's thinking, oh, my medical information, my personal things that I checked off about my gender, my sexual activity, my drug use, my alcohol ingestion is all going to be public knowledge. And then, again, we all get sometime as an employee matching contributions to our 403B or 401k plans and all of our insurances. In my practice, I pay for everyone's licensed DEA, state society dues, and at least a CME meeting a year, and that all adds up. Okay, a few things about working solo or directing CRNA care and care team models. So this I accessed just about 6 months ago now, 7 months ago, from a nurse.org website. You could see CRNAs in the country are averaging about $250,000 a year. I was speaking to some people today who can't find a CRNA for less than $300,000 a year. So I think this may already be out of date, especially in some of the geographies where we work. Now, the other thing, strangely, is most CRNAs have better benefits than the doctors. I don't know if you're aware of this, but where I work, the CRNAs are in the nurses unit. They get pension plans. They work 30 years as a CRNA. They are doing extraordinarily well. Although no one actually thinks of that as their pay, they still want to be paid the same as the doctor, even though then they'd retire in a much better circumstance than I might. They also have generally more time off, and because of the nature of the workforce, both by age and sex, they're a little bit more likely to take more FMLA time and more sick time also. I use this spreadsheet to figure out the costs of MDs that work alone versus those that medically direct CRNAs. And this is a 2-to-1 example to start, and I'm just going to talk about this for a minute. Most people don't believe me when I tell them this, and then they email me a request, and I send them the actual sheet. So I have on the left side of this is CRNAs are coming to work 3 days a week because the end of my day is never predictable. And on the right, I'm pretending that I could get the CRNAs out in under 10 hours a day, and therefore they're working 4 days a week. The only numbers I'm inputting here are my total CRNA cost, my total MD cost, and how often they are off a year, so I could figure out the exact number of FTEs I need to hire to run my operation. And if I just think in a per 2-room increment, an MD that supervises 2 CRNAs will cost me $500,000 more than if I just have 2 MDs come alone every day. Because those CRNAs, they're only showing up 3 days a week. And I need 10 shifts worth of coverage. I need 3.3 CRNAs before anybody takes vacation or sick call just for 2 to show up every day. So as soon as 3.3 CRNAs out-earn 1 MD, I'm behind the 8 ball. And even when they work 4 days a week, I'm still pretty much behind the 8 ball when I think about this in my 2-room increments. That makes the arithmetic easy to digest. And then if I go to an ASC or something, I just put in how many rooms I'm going to cover, and you can see how the expense adds up very, very quickly. I have a spoiled group. They think covering anybody more than 1 to 2 is like sacrilegious or somehow going to lead to the end of the earth. So, but even the 1 to 3 coverage model is not very good when you have CRNAs, again, working 3 days a week. Per 3-room increments, you're losing less than you were losing per 2 increments in the other model. But when all is said and done, you're still behind the 8 ball versus getting MDs to work alone. That maybe their total cost is $600K a year. It's not until you get them to show up for 4 days a week that it works out that you kind of come a little bit better than break even. So I had the spreadsheet set up. I could put any number in these yellow boxes I want, and it just spits out the data. I've done it for a few people. Or I just sent the spreadsheet to some people around the country. If you email me, I'll send it to you. Here's something I was approached with, trying to disprove my prior slides. I was asked to staff an ASC that was a 4-room ASC. And I was giving a pro forma, and they said, well, I think you could do this much more cheaply with CRNAs. You know, I think you're pulling the wool over our eyes. So this assumes that in New York City, first of all, I could find CRNAs that want to work 5 days a week. I haven't discovered that entity yet. That the CRNA's compensation is only a total of $300,000 a year. That the CRNAs will each only take 25 days a year off of work, sick call and everything else included. And it also ignores the number of staff rounded up to the nearest whole number, intentionally. And it assumes also that the entire day is an 8-hour day, not room start to room end, but the whole day is an 8-hour day. So this is entirely fake news. And I had to explain that to the person that generated this chart for me. So whenever you're faced with data, just take a big, deep breath and understand what the other person's idea is. There's no way my ASC is going to run a room from exactly 8 a.m. to 4 p.m. or the actual whole ASC. The room's going to have to then run from 8:30 to 3:30, and if we stay until the last patient's discharged or at least medically ready, that's always going to be more than an 8-hour day. Okay, so I showed a lot of data there, but this is the big picture. If you have nurses working 3 days a week, 12-point-hour shifts, supervised 1 to 2, you're losing a lot of money if you could just do those rooms with an MD alone. If you have CRNAs working 4 days a week, supervised 1 to 3, you're a little bit better than break even, maybe, or at least you're not losing a huge sum of money. Okay. I didn't talk about 1 to 4 coverage, which I know is also very, very common. Because I have trouble enough getting people to work 1 to 3. So the rules of medical direction are very clear. And these are the rules. As the anesthesiologist, you're supposed to be involved in the preoperative examination and evaluation. You're supposed to prescribe an anesthetic plan, personally participate in the most demanding aspects, including induction and emergence, monitor at frequent intervals, be physically present for immediate diagnosis and emergencies, and provide the postoperative care indicated. Anybody that does CRNA supervision, that's doing electronic billing, you have something like this at the end of your statement when you attest to the bill. Now, I'm just going to forget about anesthesiologists for 1 minute, talk about surgeons. Some of you may remember these Boston Globe articles that occurred in 2016 and 2017. These were claims made by patients. I had no idea he was sharing Dr. X with another patient that morning, talking about their surgeon. Learned her surgeon juggling 2 ORs necessitated a more powerful anesthetic than she wanted, probably a longer anesthetic than they wanted, right? The allegations underscore the growing concern over surgeons who boost their volume and revenue by overseeing 2 or more operating rooms. How many people work in centers where the surgeons at least have overlap or outright concurrency with a second surgeon who sometimes maybe could be there? Okay. Well, that could get you in a lot of trouble, right? You look at these follow-up articles, double book surgery, a death. They got to pay millions of dollars. The whistleblower got $13 million. I wish I was that guy. Right? 3 years later, this is MGH. This isn't Podunk General run by a bunch of, shady characters. 3 years later, again, same thing. 3 out-of-court settlements, $32.7 million, and lots of bad publicity, right? So what does that have to do with anesthesiology? Well, I could see I could be scrutinized for directing 2 different rooms, right? Someone could say this about me, perhaps. Oh, I thought Dr. Leibowitz was only with me in GP18. I didn't know he was with me in GP19. They're not going to care that I could literally see the 2 rooms through the glass between the 2 operating rooms. Learned her anesthesiologist juggling 4 ORs necessitated maybe not a more powerful anesthetic, but you know how sometimes regional anesthesia takes more time and effort? Well, maybe a different anesthetic than the one she wanted, because you were just at 4 rooms. You didn't have time to put the input into the ultrasound machine or whatever else maybe you needed to do. And maybe someone can make these claims about anesthesiologists, not just the same as surgeons. So I think that we have to be very wary of who we're supervising and where, and that the people we assign to do 1 to 3 and 4 coverage really meet these expectations. And they give patients the knowledge that they might be concurrently covering, but they're going to be there for those 7 things they're supposed to be there for. Okay, on to some billing jargon. So revenue cycle is all the functions used to create a bill, collect what is due, and maintain a handle on what I call your key performance indicators. This goes back to one of these management books that people in business always talk about, that what gets measured can get managed. I wouldn't always say that it does get managed, but it can. Okay? So if you're just starting out, the key performance indicators that every practice relies on is definitely case count, anesthesia units accrual, gross charges, gross collections, net collections, gross collection rate, accounts receivable, and in dollars and days, and payer mix. I covered a lot of these things already. Charge lag is the thing that usually really bugs us, and that means I take care of a case and the charge doesn't even end up in the insurance company for weeks for one reason or another, and that means I don't get paid for even longer. And this doesn't have to do with charge denial, which is a fact of life. And I think everybody's probably read that the insurance companies use AI to deny all the charges. Like I sent a random number of charges, and then if you're in a good institution, you use your AI to deny the denial. But it's not uncommon that could go on forever. Remember, we covered this before, and for the sake of expediency, I'm just going to repeat. You need a source document with your signature that is all the correct demographic information, the insurer information, the correct procedure, side levels, correct diagnosis, and if you're supervising anybody, it has to have your attestation that you did those 7 things, right? After all that's done, it has to go to a coder. Anyone know how many coders there are in the country? There are more than 70,000 coders working on claims. Some of them are in India, but there's 70,000 coders working on medical claims in the United States for United States physicians. And then it goes to a biller. These may be 2 separate entities, and then they get it to the insurer. And remember, the insurer doesn't want to process your bill very quickly. The sooner they process it, the faster you get paid. Their money is then out of the bank. Same reason you try to pay a credit card at the end of the cycle. That's why we all have accounts receivable. Bills are not paid instantaneously. On average, depending upon your operation, a bill may take somewhere between 45 and even 60 days to collect on, even from a clean bill submission. Usually accounts receivable is all the outstanding charges, and the days in AR are basically all the outstanding charges divided by the charges that you average per day. And a nice way to look at sometimes is look at this in buckets. Most of all the money you're owed should be in the 0 to 60 bucket. This was a little cleanup project I did a few years ago. I went from having only 58% of my money in this bucket up to 68. That's a pretty good thing. Charges that are out here after 120 days, you could almost write them off. The likelihood of collecting that money goes seriously down. People move, they die. They're definitely not going to pay you the out-of-pocket copay 6 months later. So again, Gross collection rate is collections divided by charges. Sometimes that's inaccurate because we charge what we want the commercial insurers to pay us, but we get Medicaid and Medicaid rates from all those other patients. So sometimes we go with allowable charges or net charges to get a better handle how our collections are actually going. So I suggest everybody have a net collection line. And there's a little bit of a disconnect here. If you have a large out-of-network practice that you will eventually get paid from, I wouldn't care about the AR as long as eventually I get paid. I have this, one of the orthopedists said, well, why do I want to accept $10,000 to do the spine? I'd rather wait 9 months to get $100,000. Who wouldn't want to do that? Right? So there's a little bit of a different take amongst proceduralists whose charges are very high. So if you're being approached about a bundle, that's like an all-inclusive vacation resort, right? The concept is the insurer pays a global fee, and us in the hospital and all the other doctors get paid from that fee. Until now, usually the insurer determines this based upon prior costs using a reference hospital, perhaps. And then if you do better, they share a little bit of that money, and if you do worse, it has to be very clearly spelled out what happens. The problem is sometimes you get a big outliers. You know, you're doing the total joint, you're supposed to be paid $1,000 for the total joint, and the orthopedist $5,000, and the hospital $15,000 maybe. And then the guy has a myocardial infarction, and he needs a stent, a balloon pump, a cabbage. He's in the hospital 3 months, and the hospital bill, the total bill, instead of being $25,000, which is not uncommon for all these charges for total joint, is now $425,000. Well, we only did 400 total joints. How are we going to pay this one off? We're going to all make no money, perhaps, right? So you have to get in line with what's going to happen to the cost of the big outlier. And if there is savings, who's going to get it? So far in my institution, it's almost always the hospital and the surgeon. None of these other people have gotten a penny. It could lead to, basically, I would say, things that might be good for patients. Sending people home early is probably good. I and my wife now have had a total of 3 total joints, and we both were home for dinner, all 3 times. Not sending people to a subacute nursing facility works very well. That's where most of the cost actually is. We don't send anyone to subacute nursing facilities anymore. Mount Sinai, to my knowledge, are a very, very rare patient. Stop calling consults. If you're charging for a pain block and you're in a bundle, you're not going to get paid for the pain block. You're going to have to negotiate for that total payment to include the pain block up front. Okay, so I have 4 more minutes left here. These are the main things I think everybody in the audience knows up here about managing rooms. I have these other little biases. I like to sometimes look at anesthesia start to intubation time as a measure of my anesthesiologist efficiency, intubation to incision as a measure of OR team efficiency, incision to surgery finished, that's surgeon efficiency. And I think anesthesia competence is getting the patient extubated at the end of the case by paying attention to the cadence of the surgery, having some knowledge of how fast the surgeon works, paying attention to the biz number, the underlying respiratory rate. Sometimes graphics really help. This is one of my poorer paying hospitals that is a mess for me. But this is a Gantt chart of how the OR looked. This is back on March 14th, but it could have been randomly any day. I have 9 anesthesiologists working in this institution. So 9 people, 1 person's post-call, 1 person's on vacation all the time. So 7 people show up, and this is what they did for the day. This is terrible. I mean, because I accrued 127 RVUs on this day, where my blended RVU rate's under $40. I didn't even make 1 person's compensation whole for the day, probably. So, you know, I'm talking to this hospital saying we should just get rid of these 2 rooms altogether. We should never ever do GI and IR at the same time. There should be. I suggested we should get rid of rooms and schedule anesthesiologists' names and just say where they need to go. And we should have 5 anesthesiologists, and when we filled all their names for the day, we don't schedule any more cases. That's how the block would work if I had my druthers. I created a similar one, slightly more sophisticated, for labor and delivery. Here's all the epidurals that are in action at any given time. Here are when the C-sections are done. Here are my yearly numbers. This is also early in March. Now I'm actually above the prior year's average, and my running average for the last few weeks. But it gives me a nice snapshot. And this is how I view my whole big practice with all my hospitals, what's up and what's down in each of these columns, in a bar chart form. and by service line, and I have some other data here also by payer mix. So I have this continually updated every day. I can look at any hospital that's, the hospital say, oh, we're busting at the seams, our volume's up, and I, no, not really. This is the source of truth. It comes directly from Epic, right? I'm gonna just tell one story that's worth a minute. When I first took over as chair, I merged with another hospital system like 8 months later, and the EPS people told me they needed to open a third room. I was short-staffed. I just hired the remnants of the faculty that were there. I hired another dozen people, and I was up to my eyeballs in administrative stuff and new on the job. They said they had a third EP room. They were only doing 40 or 50 EP cases a month, but with the third room, they could really do a lot more volume, and this would be really very lucrative. And just went to the basics. I said, I want to see your on-time starts, and I want to see the room utilization before I commit to hiring someone else. Well, I watched it for 1 month. In 1 month, they didn't have a single on-time start, not one. And their turnover for EPS was like an hour and a half. So I just simply said no. I said, when you start every case on time and your turnover is under 40 minutes, come back to me, which took about 3 years. So I didn't have to hire another anesthesiologist. The limitation in volume wasn't space. It was a limitation was efficiency. So yeah, I think everybody here knows day to day your life's made miserable by late starts and inefficiency, but on a large scale, think about how you could leverage that. So in summary, know about Medicaid and Medicare, because those are the drivers of our revenue in one way, shape, or form. They use as a baseline also that insurers think of. Know your commercial rates relative to your local averages. Know that your practice costs beyond the compensation are usually underappreciated, especially if you're an employer. They don't understand the 401k match, what their medical insurance costs and all that. Have a handle on your revenue cycle metrics. Get ready to negotiate bundled payments. Maintain a resource that does this for you. Don't rely on someone else. And then you'll have insight into your business and not rely on the hospital or some other entity to tell you about this. And so again, don't outsource these. And then the most important slide, though, is that you should spend your free time wisely, because this isn't the dress rehearsal. You should make these things work for you, not against you. And with that, I'll take any questions. This, by the way, is Dr. Schulman. He's one of the authors, along with Dr. Gall, another resident and current faculty member of mine who does the survey that's going to be in the Monitor next month, I think, Steve?
Yes, it's
Okay.
online now. It'll be in the Monitor soon. Excellent presentation. I can't believe how much you covered in such a brief period of time. I want to give you a little pushback about the CRNA 3 days a week at 12 and a half hours versus 4 days a week at 10 hours, because if you have ORs that are going that late, if you have ORs that are really going until, let's say, 7:30, 8 o'clock at night, if you don't have those 3 CRNAs covering it, then somebody else is going to have to do that. So you're going to have to then have 2 more physicians
Yes.
covering that same time. So you're going to have physician shifts that are going to somehow reflect more time on those
Yes.
nights.
So that would get into the yellow box where your physician compensation on a per FTE basis is up. Yes, that would be included in my thinking in that box. If I'm having doctors work 12 hours a day too, they're not going to be paid that 600, maybe it's going to be 700 or whatever. Yes.
Questions also about time. Are these numbers, like we have the anesthesiology around 500, are they working 60 hours a week, 40 hours a week? What is your, how many?
I'm sorry,
For instance, the annual compensation you had is 500. Are you considering 40 hours a week, 60 hours a week?
So that's not my data. That is the data reported by the medical schools, then the AAMC survey, what this doctor's W-2 was at the end of the year total, all in, whatever the hours were. And same thing for all those other surveys. So it includes all the time, all the call, all the administrative work, distributed however it might be.
So there's no number of hours average for?
No, but I happen to be working now with a company that's coming into Mount Sinai. That's a consultant company, and they look at anesthesia as shifts per year and hours per shift. So if you say an average anesthesiologist is supposed to work 223 9-hour shifts, that's the hours per year. Every hour in their mind above that would be paid some other overtime rate. Anyone else? Thank you all for coming. I hope that was appreciated. My pleasure.